Special K. All right, so the topic is ketamine. I should just, by way of introduction, point out that the purpose of this presentation, when it was going to go blank, I said, well, why don't I talk about ketamine? Because we are proposing or doing one study in 2 phases, which will be at Eagle Ridge using ketamine. And I thought this was a good opportunity to review it. I regret that I didn't find anybody to assist with the pro-con debate, so all we have is the con side. I'm sorry. I don't know. Everybody probably knows the research team here. Nick is the quitter who's leaving and going back to England, unfortunately, because he's an integral part of the team. So he's going to do sort of that from England. Dr. Guy Dumont is the engineer, Canada Research Chair in Control Engineering, if I'm not mistaken, or something like that. Aren't you? Oh, I thought you did. Well, your website says you do. Yeah. Anyway, he's with the computer engineering at UBC, and he's been responsible for many of these things through the Pediatric Anesthesia Research Team /ECEM, Electronics and Computing and Engineering and Medicine. Is that right? Close enough, yeah. Anyway, a very productive, collaborative through the Children's Hospital. As you know, we've done some studies. We've been fortunate enough to do some studies in the past using our adult patients with some of their projects. Ariana is going to present the paper. She's a research coordinator at the Children's Hospital. Aaron is the another research coordinator who's actually the on-site team. Matthias is a computer engineer, biomedical engineer, something engineer with a vast amount of experience and is part of the programming and statistical power and a whole bunch of other things. And Klaska is primarily, I think, involved with making the eye control system work and understanding EEGs. Klaska's a postgraduate engineer as well. So we're full of important, smart people here. So I thought I would start out by talking about ketamine as much as I have learned about it, and then we will move on to some of the study stuff. Interesting, ketamine is 54 years old now. It was synthesized in the United States when shortly after phencyclidine had been introduced, found to be a drug and actually introduced into clinical medicine, and then they decided that the side effects of phencyclidine were too big. Interestingly, this guy, Stevens, Dr. Stevens, Professor Stevens, went on to synthesize a whole series of analogs, and they identified this one that was CS123 or something, subsequently named ketamine, and they undertook to investigate its uses. And you notice that the volunteer subjects of this thing were located in the Jackson prison in the state of Michigan, so I just thought that was interesting. That little thing at the bottom describes why phencyclidine itself didn't last. It's quite easy to make, as you know. They all work on the same receptors, but obviously in a bit of a different fashion. Ketamine we refer to it, or it's been referred to as a dissociative anesthetic. It works, they think, partly through NMDA receptor antagonism, and this is in contrast to almost all of the other general anesthetic agents that are around, which are GABA agonists or GABA facilitators. So GABA receptors are involved with inhibitory mechanisms. So when you increase inhibition, people go to sleep. That makes sense, doesn't it? Yeah. Whereas NMDA receptors are quite different. The NMDA receptor is quite a complex receptor, and this is part of the reason that it's been challenging, I believe, to understand it, and I certainly, this is the extent of my knowledge, what I've cut and pasted. I just thought it was interesting to note that it's a voltage-dependent block by magnesium ions, which is why magnesium is being used as a NMDA receptor modulator as well. But in any case, this particular quote was stolen from the Center for Synaptic Plasticity at the University of Bristol, where they're studying all these things, and it's so NMDA is involved with synaptic plasticity, which is learning and memory function. So if you block it, perhaps you can't learn and you don't have a memory, which is sort of like anesthesia. I just wanted to make a brief comment about S-ketamine because ketamine is a racemic compound. The S isomer is felt to be the most active. We're just at a little tiny glitch there. Did this go? No, that's good. Because the screen is not quite working, but we'll have that fixed in a moment. It's actually, the S compound is released in Europe. I'm not sure if it'll be released here, but probably not, because it would be too hard to get ketamine through now, I think. It's said to have fewer side effects, so perhaps like so many of the isomeric compounds we have, the R isomer is a bit more responsible for side effects. Shorter recovery, you give half the dose, which isn't very rocket science. So ketamine, though, it's interesting, and it's a very fast onset. Onset within a minute. It's almost like propofol, blood-brain circulation time. Interestingly, it can give interosseous, which slows it down by just a half, so a minute and a half. So those who want to use interosseous administration of drugs, ketamine is a perfect agent for that. IM in 5 to 10 minutes, given orally, although apparently it tastes crappy. And they're developing a nasal formulation. And there was a couple of others, going to be rectally. Oh, really? Yeah. I suspect it's not a nasal formulation, but just spraying stuff in the nose. Yeah. So they apparently are coming up with a more formal nasal formulation. So it makes sense in kids or something like that rather than poking them. I wonder, it isn't because I've lost my second screen at my end, is it? Oh, okay. Just here. Let's try a page down then. Why are we... oh, he'll fix it. This is, oh yeah, I called this, you don't see this, but it's my Goodman and Gilman slide. It's the various things about the pharmacology of ketamine. It's got a short, it's a two-phase elimination, a short initial alpha half-life of just 2 to 4 minutes, so it comes and goes quite quickly. It's a longer beta half-life, 2 to 4 hours in human beings. They say that women may clear it a bit higher than men. I don't know why that would be. It's metabolized, mostly apparently directly metabolized to norketamine, which has some activity, which is subsequently hydrolyzed and excreted in bile and urine. It's metabolized very quickly. The norketamine appears in the blood within a couple of minutes after the IV administration. Given orally, it has a huge first pass metabolism, so it's a poor agent to give orally by virtue of that problem. Norketamine persists longer than ketamine, and that's one of the things about the drug that make it last a long time. 5 hours after administration, they say. Now, ketamine's is a really messy drug. This is a paper from just this year, Clinical Pharmacokinetics, and it shows association with tons of other receptors. The NMDA receptors and the GABA receptors are all in the brain and spinal cord, but it activates with a whole bunch of things, dopamine, serotonin, cholinergic, nicotinic, muscarinic receptors, antagonism of mu narcotic opioid receptors, although the effect is relatively weak. It also, in experimental models, you see monoamine monoamine transporters, so that might explain some of the psychomimetic effects they say, cause change in the uptake of catecholamines, that's a hyperadrenergic state, which presumably is related to that knowledge that we've always had that it increases plasma catechols. So it's a messy, messy drug. It's a truly ugly drug. In addition to this, there's becoming models of what anesthesia is. I think over the years that I thought it was due to some depression of the thalamus, and then we talked about thalamocortical communication and connections, and maybe blocking or disrupting those is why people go to sleep, and blah, blah, blah. But ketamine, as you can see from this list here, I won't read it out, but it doesn't do any of the things that it's supposed to do if it was to be a well-behaved anesthetic. It doesn't have thalamic inhibition. It activates a wake-promoting locus in the brain, blah, blah, blah. So I don't know. There is becoming lots and lots of information about it now. There's about 800,000, no, I think 160,000 papers on Google Scholar on ketamine. So, in any case, as the definition that we have used is that general anesthesia, unconsciousness, amnesia, pain relief, and lack of movement with stability of other systems. That's our goal. Unfortunately, it's a little hard to define because there's so many inconsistencies, but ketamine may work because it interferes with dynamically interconnected feedback loops. However, in this context, modeling and control of anesthesia is said to be challenging, hence this current study trying to improve that situation. Now, ketamine is said to be a dissociative anesthesia, so I had to look up what dissociative anesthetic was because it's, we use the term, but I don't know if I knew particularly what it was. So, interestingly, the term was introduced by the looks of it, as far as I can tell, with ketamine, because it was a little odd how it worked compared to, I guess, the pentothal and ether of the day. So, that was the definition that comes from a medical dictionary, and it's not terribly different from neuroleptic anesthesia and analgesia, which was associated with droperidol and Haldol and that sort of stuff. Shortly before I started, I guess droperidol was used in larger doses as basically a general anesthetic agent. By the time I started, that was being less common because it's so long acting. But when I started, it was still part of the combination with fentanyl. Inovar? No. Inapsin is droperidol. I think Inovar was the combination, wasn't it? Yeah. Anyway, that's ketamine. Now, I wanted to talk a little bit about the uses of ketamine, and obviously our primary interest is in pain management, which, again, another paper, I scanned all sorts of paper on the pain management associated with ketamine, and I like this. A large terra incognita, meaning we don't know much yet, and I think this is still still a viable comment. There's a suggestion that it's an opioid receptor antagonist that causes its effect. This was debunked in one particular study. the degree of opioid analgesia is poorly understood. Local anesthetic, because it can do that, and in fact, there's quite a few papers on ketamine and epidural and spinal, but that the exact mechanism of that effect seems to be poorly defined. It does work on receptors in the spinal cord, though, so GABA receptors, so maybe that's the thing. And that. There's a number of trials on it. One trial, this was a paper from relatively recently, let's see, March 2003, so in the modern era of ketamine, let's say, because the use has increased a lot since the turn of the century. And these guys, this is an Israeli group, and they gave it in the PACU to patients, and you can see the graph there shows very significant improvement in pain control when ketamine was added to morphine in a group of patients who had received up to 100 mics per kilo of morphine and had inadequate relief. This was in thoracotomies, laparotomy, bigger cases. Interestingly, 100 mics per kilo, you think, oh, that sounds like quite a lot, but in fact, the average patient only received 7 milligrams of morphine, so it's not a very impressive population to say that they had poorly controlled pain. And 7 milligrams is just an introductory dose, isn't it? And you move from there. But anyway, they gave, once they had enrolled the patients in the study, and they had 200-odd patients, they gave them either a small dose of ketamine and with morphine, or just morphine, a bigger dose of morphine. And the in the recovery room, this distinction was very, very significant. You can see their pain scale, this is a pain scale graph, fell dramatically. So that would be stress. It was a quarter milligram per kilogram of ketamine. So in the PACU, once they had shown that they were not responding adequately to the morphine. So it works for pain there. This was the second paper, and it is, I can't read where it's from, and they gave in gynae patients, so gynae laparotomies, and they gave a small dose of ketamine there, 1.15 milligrams per kilogram, plus a ketamine added to a PCA, 0.5 milligrams with one of morphine, so smallish doses, and they found no difference. They found no change in postoperative pain scales and morphine consumption and incidence of morphine adverse effects such as nausea and that sort of stuff. So there we are, two papers with entirely opposite findings. The ketamine group received 44 milligrams of ketamine in total, so it doesn't seem like it's too small a dose. So one moves on from there to meta-analyses, and this is Canadian. I think they're from McKay. He's from Saskatoon. So Saskatoon-based meta-analysis, and we're going to try this now. Control mouse. Oh, there we go. I don't need a control mouse. I just use that. All right, so this is the favoring ketamine side. This is the favoring not favoring ketamine side. This is the zero line, and fair number of papers showing, in summary, a small benefit in favor of ketamine. They commented, though, that this is a difficult systemic review to do because of the heterogeneity in the studies of techniques and endpoints and doses and that were all over the map. So they said that they had done a whole bunch of different sophisticated meta-analysis type techniques to try to normalize them all, but said that the study still had weakness on that basis. The review still had weakness on that basis. Treatment group did have increased neuropsych effects according to the grouping of the papers, though the effects were small. Decrease, and they say transient, decreased post-operative nausea and vomiting, and whether that's because ketamine is an anti-nausea agent or because it would presumably work and decrease the amount of narcotic use. I wanted to point out, actually this little graph here you can't see, but ketamine dose, the different doses, and they found no difference on the basis of the different dose. Like, so giving more ketamine was not more effective, which is intuitively not obvious unless there's some sort of small dose that's needed and then a ceiling effect. Well, these doses that they recorded were less than 0.5 milligrams per kilogram, 0.5 to 1, or greater than 1. Well, I mean, they said that there was no difference in things, so presumably that suggests that the less than 0.5 is as effective, right? If you believe this particular meta-analysis. There is another one. I just put this again because you can see the studies are all over the map again, and again the thing very slightly favored ketamine, but it isn't a big difference. It's very close to evens. So this is a more recent meta-analysis. This was, I think this was 2015 or something. Yeah, can't tell. So, and it's ketamine with PCA, ketamine included in the PCA. So slightly favoring the use of ketamine, but it's not a strong effect for sure. So, and then this is an editorial from this month's ACTA, which says basically that you should take, I mean, the suggestion here is you should take any pain study with a grain of salt because of these various problems with the studies, methodological issues, and blah, blah, blah. The one meta-analysis said that in patients, in fact, one of their summaries was that patients who have little pain to begin with have little effect from ketamine. It's only, or procedures, so tonsillectomy, for example, ketamine was not found to be useful, blah, 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 but procedures in which large amounts of pain are expected did show benefit from ketamine. So they said that there's no point in studying procedures with little degree of pain. So this reviewer suggests that the whole issue still remains to be determined. All right, there's a whole bunch of other areas where ketamine is being used. ICU for status, so being suggested for status, mostly on theoretical grounds. I think that, as far as I understand, there's no real big studies on it, but perhaps something to be considered when we have, that recalcitrant status where they want us to run sevoflurane by the gallon. They suggest, we were advised when we were younger not to use it in cases of raised ICP, but the change in ICP is minimal. It's considered to be a reasonable drug to use in that setting. Traumatic brain injury, that's a setting in which one looks at neuroprotection, and there's some suggestion that ketamine provides neuroprotection under some circumstances. The diminishing in chronic post-surgical pain, again, this particular reviewer just said it's possible. The evidence for this is not strong. Opioid-induced hyperalgesia, there's several papers look at adding it to remifentanil anesthetics to reduce that. Interestingly, half the outcomes supported, the other half didn't support. So it's a very, still a wide open area. In rat studies, there's some brain cellular injury, which is common for just about everything that we use. In some rat study, in higher doses, there's a suggestion of damage to neurons. It does have psychogenic concerns. As you know, that's one of the reasons why I've been reluctant to use it. Most of those studies, most of the meta-analyses have said that yes, the incidence of dreaming and funny states is higher, but it's transient and not too much of a concern. There we go. Some people add midazolam to their anesthetics when they use ketamine. There's a review says that makes no difference. Benzos don't change the incidence of neuropsych things. Interestingly, one paper which was from 2004, single dose ketamine to volunteers caused significant, relatively long-lasting, like into the next day. By 3 days they were gone, but relatively long-lasting neuropsych affects, schizophrenic-like symptoms. Back in the 60s, they were using phencyclidine as a model for studying schizophrenia. So then I'm stepping back a little bit here. I couldn't decide where to put this in the paper. There's the argument whether, in fact, the NMDA antagonism is why this drug works, because it works, propofol works, has no NMDA antagonism at all, blah, blah, blah. And there's a suggestion that, in fact, one suggestion that on the basis of an EEG model, that ketamine and propofol should be antagonistic. They'll do different effects. But there's a suggestion, in fact, that the effect of ketamine is through different pathways, the actual anesthetic effect, and not NMDA antagonism. So they, in summary, referred to ketamine as the nightmare of the pharmacologist. I like that. Now the EEG, so we're looking at using EEG, BIS and entropy, and now the neurosense monitor. I can't talk intelligently about EEG stuff. It turns out that the EEG effects of ketamine are quite different, depend on the dose of the drug and whether or not propofol is included in it. So if you want to just quickly review this gives you the brief summary of all the EEG effects. This is why we're looking at doing this next study. So our current plans are to undertake 2 studies looking at the EEG using the neurosense monitor as the monitoring device with ketamine. The first phase, or the first study, is underway at Eagle Ridge, and the second one will start once we've had a chance to look at the information gained in the first and analyzed it and decide what to do and how to program the controller and blah, blah, blah. And Ariane is kindly going to talk about the thing. You might say, well, why are these studies being done? And I don't think it's unfair to note that the company, Neurosense company, is trying to market its machine. It's not, is it approved in the United States yet? I don't think it's received approval. It's approved in Canada. And so they're trying to do as many studies as they can to market it. And one of the funding sources for some of their studies is military. And the military is interested in the use of ketamine because it confers hemodynamic stability. It doesn't interfere very much with respiration and provides good analgesia. And they figure it could be a good agent to use on the battlefield. I think at this point in time, it's not approved. But they note that morphine has been used since the Civil War, and it's still a fairly poor drug to use. So ketamine may be advantageous. The company has proposed that maybe the neurosense monitor would be a good monitor to use when they're using ketamine and other narcotics. So they're providing funding for this study, and that's the part of the basis of the ability to do this study, that they're providing funding, because you don't do these things without a source of revenue. So I'd like to pass this over to Ariana, who will. I have to stop this. Stop for a second now. Where's my mouse? Page up. Come on, mouse. Oh. I killed it. Oh well. Okay. Yeah. Okay. Just like I'm going to close this. I won't. Okay. PDF first, or no,
PDF's
shoot.
good. I don't think we have anything fancy. There's no animations or anything.
I'm not going to record. And you are Kingston D. And you are PDF or iControl?
I'm the first one, ketamine lab.
Okay. Oh.
Have to drag that window to the
Okay. let's just mirror on the two. Can we mirror? See settings? What was that screen I used?
Oh, you can actually do the Windows P.
Oh, okay, right.
This works.
This way. And I want to not extend, but duplicate. Apply. There we go. Okay, so you get to see it as well.
Great.
Okay. So Ariana, formerly Umadali, Rollinson is the
Change it up when you get it. Yeah, I met a bunch of you here. So Richard talked a little bit about our closed loop work that we've done, and so that's probably where I've met some of you before. We did a study here at Royal Columbian with the Remy fentanyl and propofol controller, and I was mostly part of the phase 1 of that study, and my involvement now is a little bit more limited to the regulatory side. So our closed loop system is something that needs to go through Health Canada approvals and such, and so that's kind of where I'm involved at the moment. But I'm going to tell you a little bit about the 2 studies that we talked about that are involving ketamine. So we talked again about the U.S. Army's interest in using ketamine, and also they're interested in the closed loop control. So we realized that before we undertake a study between the 2 of them together, probably need to do an initial study because we don't know a whole lot about exactly how ketamine affects the EEG and in what quantity we can expect it to not significantly affect the EEG, and that's important because we use that to as the input for our controls. So the first study we've called effective ketamine on the WAV index. So that is the measure output by our EEG monitor that we're using, known as the NeuroSense. And so the purpose of this is really to look at 2 different doses of ketamine and to compare them to an equivalent anesthetic without ketamine, and to make sure essentially that the EEG that we're getting is reliable when we're giving either of these 2 doses, and to use whichever dose we deem reliable in the following study. We're also going to be looking at some postoperative patient outcomes, looking at opioid requirements after surgery and pain, nausea and vomiting, shivering, and asking the patients a few questions about dreaming and awareness. So the first study, it's patient blinded. The anesthetist is also blinded to the NeuroSense. There's 3 arms to the study. The first one is a higher dose of ketamine, the bolus of 0.5 milligrams per kilogram and an infusion of 10 mics per kilo per minute. We have a max dose of 200 milligrams over the duration of the case. We have a second arm also with 10 subjects going to be enrolled to it with essentially a half dose, and then a third arm with no ketamine at all. So that's just a equivalent anesthetic without the ketamine. So we're doing this at Eagle Ridge. There'll be elective ACL repairs that are scheduled for over an hour, and healthy patients. Lots of exclusion criteria. So mostly contraindications to any of the drugs that we're using, and things that would cause us to suspect an abnormal EEG, because again, we're looking at that information. But this will be mostly the RA's job to look for all these exclusion criteria. So as far as the actual study procedures themselves, we'll have the NeuroSense monitor on before the patient is induced. All of the drugs will be given via infusion pump. There'll be a ketamine bolus, followed by an infusion rate, which I'll go into afterwards. There's also Remy and propofol boluses. We will ask you to help us look at the loss of eyelash reflex and record that point in time. We'll take note of that. And as far as airway, ETTs or LMAs and neuromuscular blockade can be used, but in those cases, we would want neuromuscular transmission monitors to also be used to assess the level of paralysis. For maintenance, the infusions will be automatically programmed into the pump. So as soon as the boluses are done, it'll go straight into the infusion. And there'll be, again, 3 arms. So larger dose, a half dose, and then no ketamine at all. We do have starting rates for the propofol and remifentanil. but those can be adjusted. And rescue procedures, so of course we can give propofol boluses, they need more, remifentanil as well. The ketamine can be reduced by 50% or turned off if we feel that's necessary, and hemodynamics can be managed as you see fit. As far as emergence, would taper the propofol and remi towards the end of the case. We'd try to limit longer-acting narcotics to the last 30 minutes, just to minimize the impact on the EEG, so we can look at that more cleanly. We'd turn off the ketamine infusion, or if there's no ketamine, of course, that infusion as well, when the last suture is in place. And we'll be looking at some time points during the return of consciousness period. So movement, chewing, coughing, eye opening, and asking the patient if they're having any pain and seeing when they in fact respond to that. And then the PACU, there'll be a little bit as well. So doing some pain scoring both at rest and upon knee flexion, looking at their opioid meds, any postoperative nausea and vomiting, shivering, and again, there'll be a brief questionnaire on dreaming and awareness. Okay, so this is now all leading up to our bigger study. So we're hoping to start this sometime in the new year. It'll be probably after we finish the first study because we want to know the results of those. This study is currently sitting with the Ethics Board and also with Health Canada. So we'll need those pieces to be approved before we move forward with it. So now this is looking at essentially the same controller that we used here at Royal Columbian for propofol and remifentanil, but seeing when we do administer a ketamine infusion alongside it, if the controller performance is comparable. So again, looking at whether controller performance is equivalent when we give a standard dose of ketamine to the closed loop TIVA. And we're also looking at some other patient outcomes similar to the first study. So this is a randomized study, double blind, so all of us are blinded to whether or not the patient is going to be getting ketamine or saline. We'll be having pharmacy help us with drawing up the study drug, and we will see the values of the neuroscience monitor during this study. And our propofol and remi will be administered by the controller, so that should be a standardized way of administering TIVA between the two arms of the study. So this will be 60 patients, 30 in each arm, where this here is assuming that we're going to go with this dose of ketamine, but again, depending on the results of the first study, that could potentially be changed. Same inclusion criteria as for the first study, looking at the same patients. Same exclusion criteria, long list there. As far as induction, again, we'll be having the NeuroSense sensors put on the patient before induction. The controller does induction, so that's very important. It uses the EEG feedback. There'll be a study drug bolus. So again, that could be ketamine or it could be normal saline, an equivalent volume, and that'll be given over 60 seconds. Eye control will do the induction with propofol and remifentanil. We'll be having the patient count backwards from 100 and use that as one measure of loss of consciousness. We'll also ask for some help getting loss of eyelash reflex. Once eye control has achieved a patient state of below wave index of 60 for 30 seconds, we're considered to have induction complete. Airways, again, ETTs or LMAs, and if we are using any neuromuscular blockade, we'd want some monitoring for that as well. Maintenance, study drug will continue to do its thing. Propofol and remifentanil will similarly continue to operate under a closed loop. We do have some ability to control our propofol and remifentanil infusions. We can target different set points depending on whether the patient needs to be higher or lower, and also alter the remi baseline rate. And so again, there will be fluctuations above and below the remi baseline rate, but that baseline rate can be changed depending on whether we need more or less analgesia in that patient. And hemodynamics managed as you see fit again. Rescue procedures, if we need to, study drug can be reduced by 50% or turned off. If the patient is too light, we can target lower WAV index, so the controller will give more propofol also propofol boluses can be given through the system. Conversely, if the patient is too deep, we can target higher set point, and we can also pause or discontinue either of the infusions. If we anticipate any significant painful stimuli, the REMI baseline infusion can be increased. We can also bolus REMI. So, of course, our controller can't be predictive because it's responding to the EEG. So if we have information about the fact that's going to happen, we can preempt that a little bit. During emergence, we can taper the propofol and remifentanil. So now that we're using the closed loop controller, the ways that we do that are by increasing the WAV set point, so targeting higher and higher WAV set points so that the patient can come up more slowly over the last period during the case. REMI baseline rates can also be decreased. Again, limiting long-acting narcotics to last 30 minutes. We turn off the study drug infusion once the last suture is in place, and we're looking at the same measures during the period of return of consciousness. Again, in the PACU, similar, doing pain scoring, looking at post-op nausea and vomiting, any shivering, and the same dreaming and awareness questions to the patient. And that's pretty much it. Are you taking questions?
One right now.
Might be something that you might want to look at doing, I would think, ask about hallucinations or bad dreams, that kind of thing. It's a known side effect.
Like a 24-hour one?
Or even a few days later.
Yeah. Is PONV prophylaxis just at the discretion of the anesthesiologist, or is that protocolized based on like risk factors -1 or some sort of a?
I don't think we've protocolized any nausea.
Because if you're just, I don't know if you're looking at it as an endpoint or as a secondary thing, but that would be something to.
No, yeah, we haven't done that. But you're right, we are measuring. Yeah, we are looking at it afterwards. So we'll definitely be recording all the medications that the patients are getting, but we haven't.
We didn't protocolize it because we want to keep the protocol as simple as possible.
Okay.
And it's very much a secondary outcome.
Okay.
In your exclusion criteria, you have drug misuse or use. Does that include marijuana?
Well, that's not a
I don't
drug.
I mean, what do you have specifics there?
There was a specific list. I can't.
Yeah, we have a
Joe-
longer list.
There's your patient population.
I don't think it's actually written down on the list.
Uh-huh.
Chronic alcoholism is one,
Mhm.
but
Marijuana.
I think
It
it might
makes you
be.
wonder.
How do you find?
It kind of might be if it sounds like
Yeah,
it's
right.
a
If they
lot.
tell you.
Maybe not.
Yeah.
Okay, which is these?
Does that happen if I
Yeah,
have
that-
EGA?
PDF or PowerPoint?
Oh yeah.
Okay, this is Dr. Dumont. He's the Peter Wall chair. That's what he is. I wanted to thank the Chilliwack people over there, but they've disappeared, so I guess.
No, they're still there. Lorna's there.
Yeah, the bunch of them just got out.
Oh, did they? I still see Lorna there.
Okay, just the last 10 minutes, a
She's
quick
working.
refresher on what eye control is. Okay. This one? Right, she would be like this. Okay, so here you have listed the team that works on eye control, and a lot of people are here, except for Mark and Sermino, who unfortunately couldn't make it, and distributors. All right. Yeah. That's okay. So eye control. Our goal is to develop a certifiable closed-loop control system for anesthesia, and that ideally, eventually, will control the three major components of anesthesia: hypnosis, analgesia, and areflexia. So eye control RP right now is really looking at these first two elements here, hypnosis and analgesia, through the same feedback signal EEG. So as I said, our goal is to get a system that can eventually be certified. So that means that all the components have to be certifiable. The monitor and sensors right now are certified and approved by Health Canada and in the EU. It doesn't have the FDA yet. The company is working on it. Actuators they are just the standard infusion pumps, so no problem there. But then algorithms, user interface, and the software implementation. I cannot overstress the importance of software implementation. It has to follow very strict software engineering standards so that every line of code can be justified and the software has to be traceable. So we have a software engineering team here that is really a key part of this development. So the sensors, the NeuroSense monitor that you've heard about, so that's an index that we developed specifically for closed-loop control, and in particular, as opposed to the BIS, for some of you who know the BIS, the NeuroSense reacts faster, so it essentially doesn't have any delay, whereas the BIS has a very long delay that can also change, anywhere from 20 seconds to a minute and a half. Here we have no delay. So that was developed at UBC and is being commercialized by that company out of Cleveland. So that's what we use for our feedback signal. Control algorithm. We have a few control engineers on the team. So the control algorithms are based on rigorous control theory. Just yesterday, there was an IEEE blurb that was published that was saying that the use of AI makes the guarantee of safety for autonomous vehicles or self-driving cars very difficult to achieve. And that's because AI is very hard to analyze. Whereas what we use here is solid control theory so that we can prove things. And in particular, we want to be able to guarantee the safety, the stability, and some level of performance in the face of the interpatient variability. And so we do a lot of those studies, and then the software implementation is validated, tested extensively, and also we've performed a lot of usability studies. So the system was first, well, an original version of it was first tested in 2009, 2010. For that, we went to France for its greater ease of getting the regulatory approval for that kind of study at the time. So we did a number of patients there in a number of procedures, and we published those results at ASA in 2011. Then our next study was done at BC Children, and that was involving just the manipulation of propofol, not remifentanil yet, and that was done during endoscopy procedures at BC Children. And the main challenge there was to keep the patients spontaneously breathing. That means that induction had to be done fairly gently so as not to produce apnea. And for that, we did 102 cases, and we published a couple of papers on that study. The next study was performed here at RCH. So the phase 1 was essentially the same one drug controller with remifentanil in TCI mode. And the objective of that study was to collect data to allow us to model the effect of remifentanil. So we did that on 58 cases, and that allowed us to design now what is known as eye control RP for remifentanil propofol. And that eye control RP was then tested on another 80 patients here at RCH. And right now we are analyzing the data and we are starting drafting papers. Here are just a couple of cases. So this first one here is a young, healthy patient, and you can see here the controller. So after induction, so there's a bit of overshoot here, but after that it manages to keep the depth of hypnosis at set point. What you have here is the infusion rate for propofol, infusion rate for remifentanil, and here these are the effect site concentrations computed just using standard PK models. Okay. Here for propofol we use the Schneider model, and for the remifentanil the Minto. And here what you have it is a reaction of the patient, and a tourniquet was released at that time, and you see that it resulted in an arousal as seen from the depth of hypnosis monitor. And in reaction to that, both the propofol and the Remi, and you can see a large increase in the CE of the remifentanil. And the premise of that controller is that any fast arousal as seen by the depth of hypnosis monitor is attributed to a nociceptive reaction. Hence, it is counteracted for mostly by remifentanil, which is a short and fast-acting drug. So that's the basic principle behind manipulating two drugs based on just one monitor. Here is another patient. Here what we see is that this patient here, so that's an elderly patient, and in those patients quite often we see that they are not requiring a lot of propofol, and that's the case for this patient, because here the patient will essentially hit the lower constraint in terms of the CE of propofol. So for safety reasons, the clinician has the ability to set those constraints, the lower limit and upper limit that the system can achieve. So here you see that for a long time, that patient here was kept at the lower CE limit. But the remifentanil here, you see, is becoming quite active, because you can see here some more variability in the depth of hypnosis, which once again is attributed mostly to nociceptive reactions. So what's next? We still have some optimization to do, because what we've noticed at RCH, particularly in elderly patients, right after induction, we had some problems with hypotension, and so we need to resolve that. And also, in a lot of those patients, we had a fairly large occurrence of burst suppression, and that is periods of more or less flat EEG, which we think is probably not good for the patients. And there is increasing literature, particularly in the elderly patient, that tends to relate that to postoperative cognitive dysfunction and the delirium. And it's, as I said, it's typically observed in the older patients, although I might argue about this, the use of this term here for 60 plus. So what next? We obviously want to solve these two problems, so we currently doing some work on understanding the burst suppression problem, and particularly improving the estimation of burst suppression, because we think the current monitor does not necessarily do a good job on that. And now obviously we want to look at a different combination of drugs, and the next study is one of those. And if we want to look at use of ketamine as it was said during the two previous presentations, that's because our sponsor here, they have this U.S. Army, U.S. Navy research contracts, and in the military, they use ketamine quite a lot. So we want to ensure that the closed-loop controller is not going to be too affected by the presence of ketamine. And so we want to make sure that both the monitor is still giving us a good indication of a depth of hypnosis in the presence of ketamine, and once we are reassured of that, then we also want to make sure that the controller itself is going to work in the presence of ketamine. Okay? And I guess that's the end of my presentation. So if you have any questions.
Have the physician or the anesthesiologist regulate their propofol and REMI. If you're wanting something more consistent, wouldn't it have been better to have the NeuroSense eye control?
Well, because we don't know right now what eye control is going to do, and we don't really know the effect of ketamine on the index. So
but you're putting in a really random effect, because well, certainly I'm speaking for myself, I don't know about others. I don't do a lot of TIVA, which obviously at Children's would be a different story because they do a lot there. Is for me to go in to do a TIVA anesthetic, it's fairly random. I mean, I'm doing it as I've been taught, but it's not something I'm that comfortable with.
So we've given like a starting dosage, at least. I mean, yes, you're right, it can be turned up and down.
Yeah, it's fairly random.
Well, I think the idea is that, I mean, you want to give an anesthetic. So the ketamine is in the background, and we have a bit of an idea of what ketamine is going to contribute in terms of depth of anesthesia and pain relief. And then give an anesthetic. And the TIVA model is more appropriate because this is the model that the eye control controller is using. But you're right, we're not that familiar with running it, but it's not rocket science either. If they respond,
well, I think having done some of your eye control stuff, I realized that it is much more rocket science than I've been doing in the past. So
no, I think getting used to TIVA is just getting used to it. And, you know, if the patient responds and the blood pressure goes up, give more narcotic or more anesthetic.
And Wendy, there's an app for it as well. There's some great TIVA apps.
Yeah.
There's an
Yeah,
app for
but
everything.
then, I mean, we're using it, what I don't understand, if we just use the eye control to start with,
But we don't know whether the monitor is any good.
with the ketamine, but
With
we
ketamine.
don't know if it's any good with us either. I mean,
Well,
I'm not sure why we are better
even
than
look at it. So
Yeah, you're not going to be able to see the monitor, but we have to assume that we're giving the basic clinical anesthetic that we always give. So,
No, I see that, but from a study perspective, I thought if you had more control.
well, we're
like
going
the eye
to, I
control.
mean, that's the point of the first phase, to see whether it is controllable. And then the second phase, we'll see whether the control actually works. Is that fair enough?
Yeah.
Yeah,
Did you text yourself?
the first study is necessary also because, as Richard said, the studies that have been done with ketamine are not comparable. If you look at the literature, the dosage is like from a 10th or a 20th to like 20 times, 40 times. The dosage that they look at for analgesia is really small compared to the hypnotic dose. The dosing that we're looking at here comes from a recommendation for postoperative pain, I think, which also seems quite random. And so people have looked at the effect of ketamine on the EEG monitoring, mostly on BIS, which works quite differently from the wave. So no one has looked at what ketamine does on the wave specifically, nor at those doses. And even if you look at low dosing ketamine, the effect on the BIS, the studies are somewhat contradictory. So the effect of ketamine generally on the EEG has an effect on higher frequencies, which is contradictory with what propofol does. So the problem with controlling it would be that you're reading a higher wave value than what corresponds to the actual anesthetic. So you might be overdosing the patient. So before we do a closed loop study, that would be the ultimate way of looking at whether ketamine has an effect as well. We really do need to see what the effect of ketamine on the specific wave index
In one paper I came across, I didn't quote it, said flat out that the entropy monitor cannot be used with ketamine.
That's right.
But you're not using ketamine here. What's the aim of using the ketamine for its analgesic effect or for its hypnotic effect? Or for both?
Only
analgesic.
Yeah, the
Okay.
dosages are in that
Oh,
analgesic
okay.
range. They're not.
And they're really like a 10th or a 20th of a hypnotic dose.
Mm.
Fairly low.
But
even
yet
those
it does decrease what I've found using ketamine is that it decreases the amount of anesthetic you need for hypnosis. And why, I don't know, but I've certainly found that. So are we actually lowering the hypnotic dose of our other drugs? But it'll be interesting, you guys will be able to tell us, hopefully.
Well, once we close the loop,
Yeah, you'll
that
be
will
able to
tell us, yes.
Mm.
Actually, I didn't look at, one of those papers said that propofol and ketamine should be antagonistic in terms of anesthetic effects by virtue of their chemistry, right? But I didn't look at anything with ketamine and vapors, so you're talking about vapor
ketamine
anesthetics.
and vapors, yeah.
And maybe they work different. I actually don't know how vapors work. I don't know how anything works anymore.
Based on hemodynamic endpoints?
Well, that's all we have, really.
Yeah, so she's not using
Yeah,
EEG,
I'm not
yeah.
using EEG of any sort. That's why I say what I do, I don't know about anybody else, it appears fairly random once you've actually used the eye control, because it just seems so much more specific, and you're looking at different parameters. I mean, it makes sense to have more parameters to look at.
So the system currently doesn't take hemodynamics.
But
measures
we're
into
there
account.
to change we're there monitoring the hemodynamics with eye control. So you are taking it into account somewhat. It's not, the machine's not taking it into account, so you just.
Yeah.
There was a paper from Germany or France, Germany, I think, that looked at also controlling hemodynamics
Yeah.
using phenylephrine infusions and,
Wow.
and the clear sight monitor,
Maybe it
and
should be-
had about 7 different controllers in this one room. Anyway, thank you very much. I guess we run over time. And sign and fill out the evaluations, please.